Thank you for the kind introduction. And I want to thank the organizers for inviting me, and thank you for our previous speakers for an excellent first session. So we're going to completely switch gears and talk about neurodevelopment in children. So the impact of sedation and anesthesia in children in terms of neurodevelopment has been a hot topic, certainly amongst the anesthesia community, and it's a topic of controversy and intensive research. This is over the last decade now. So to summarize that in 15 minutes, I think it's a really tall order, but I'm not sure I'll be able to do that. But what I will attempt to do is to give you an overview. I'll speak on the rationale for using sedatives and anesthetics in critical care. And I'll speak about some neurodevelopmental concerns with these sedatives and anesthetics, particularly about the phenomenon of anesthesia-induced neurotoxicity. We'll look a little bit at some preclinical studies as well as clinical studies, both in anesthesia and in critical care. And with that in mind, we'll see how we can approach sedation and analgesia in the ICU. So there's wide difference in practice of using sedatives and analgesics in critical care in different parts of the world. But ultimately, the aim is to reduce anxiety and distress in the children, prevent inadvertent pulling out of tubes and lines, to facilitate mechanical ventilation and improve ventilator synchrony, as well as to reduce metabolic rate and oxygen demand, and allow better tolerance to therapeutic and diagnostic procedures, things like high-frequency ventilation and ECMO. Now, also, one of the reasons why we use sedatives and analgesics in the ICU is that we know that pain and stress is associated with negative impact, negative consequences. We know that neonates who are subjected to pain and stresses have higher risk of long-term adverse outcomes. For example, they have decreased brain and body growth, poorer cognitive and motor function later in life. They can have altered pain perception, as well as emotional and behavioral problems. So we know pain and distress is bad. Yet at the same time, we're also knowing new data now that has shown that there may be some neurodevelopmental concerns associated with the very sedatives and anesthetics and analgesics that we use to treat pain and distress. We now know that sedatives and anesthetics agents, they're powerful neuromodulators that have got the capacity to permanently change the structure and function of the central nervous system. In the short term, we can see it in ICU patients in terms of delirium, as well as withdrawal symptoms when these sedatives and anesthetics are stopped. And in the long term, we now have evidence that there's a possible impact on the children's and infants' neurodevelopment. Now, in December last year, the US FDA issued a safety warning, requiring that safety labels be put on sedative and anesthetic drugs, warning that the repeated use and lengthy use of general anesthetic and sedation drugs during surgeries or procedures in children under the age of 3, as well as in women in the 3rd trimester of pregnancy, may affect the development of children's brains. The drugs that are affected that require these labels include the familiar drugs that we use in the ICU, including midazolam, ketamine, propofol, thiopentone, etomidate, as well as all the inhalational anesthetic agents that we use. Now, this move by the FDA is controversial. It's caused a lot of concerns, and primarily is actually backed by over a decade of research and preclinical studies as well as clinical studies. What they're concerned with is this phenomenon called anesthesia-induced neurotoxicity. To understand this, unfortunately, we have to look at the developing brain. Early in neonatal development, when a baby is born, we have more neurons than we ever need, right? So it's excessive number of neurons. The newborn period is an exciting time where you have exuberant synaptogenesis. Connections are formed between the neurons. And neurons that are not taking part, that don't take part in this synaptogenesis are eventually pruned away by this highly regulated process of programmed cell death called apoptosis, which can be responsible for pruning elimination of up to 50% of our neurons. Now, as I said, this is a highly regulated process as the brain develops to achieve its normal structure and function. And it is this process that is thought to be disrupted by anesthetic agents. GABA and NMDA receptors are thought to play an integral part in early brain development, and it's thought that the interference with the normal function during this critical time can lead to abnormal neuronal survival and function. As we know, the vast majority of the anesthetic and sedative agents we use are either GABA agonists or NMDA antagonists. So there really is a molecular basis for this to take place. At the same time, opioid receptors are also expressed early in the developing brain and spinal cord. And we have evidence as well that exposure to opioids during critical periods of neuronal maturation can lead to permanent changes in the structure and the function of the CNS. How do we know this? Well, I think there's been sufficient animal studies to provide us with definitive evidence that exposure of young animals to almost all the anesthetic and sedative agents that we used above threshold doses and durations during a critical period of brain development will cause widespread neuronal apoptosis, and subsequently, when these animals are allowed to grow into adulthood, they exhibit neurobehavioral abnormalities. This happens to the vast majority of the drugs that we use, with the exception of a couple. You can see this very visually. This is one of the earliest studies in anesthesia, looking at rats. And the green boxes are control rats, which have not been exposed to anesthetics. And the red boxes are corresponding brain areas of rats exposed to 6 hours of midazolam, nitrous oxide, isoflurane, which is quite a common anesthetic cocktail at the time in 2003. And this is caspase-3 staining. As you can see, the black dots are the areas of apoptosis. You can see that the exposed animals have got a much more extensive apoptosis compared to the control rats. And this experiment has been repeated multiple times in various species, and now is without a doubt that it happens in primates as well. It happens in all animal species, but we don't know about humans, right? So the areas that are affected, most commonly are hippocampus and parietal cortex, areas associated with memory and learning. So the natural thing is then try to extrapolate this to humans. So what about humans? What about clinical studies in anesthesia? Well, there have been many done since, and the results are mixed. It's not possible to go over the individual studies in the interest of time. But we now know there's evidence of long-term impact of anesthetics on sedatives, although the evidence is much less clear compared to animal studies. Most of the studies are retrospective, and so far no causality has been established. So if you look at the anesthetic studies as a group, there's several retrospective studies on GA exposure in children below the age of 3 or 4. They're based on populations. And this has shown an increased risk of some of these studies, I would say not all. Some of them have shown an increased risk of learning disability and behavioral problems in exposed children. And there's some evidence for a dose-related effect as well. So the more general anesthetics that you have, the more likely you are to have problems. And of course, people are interested in academic achievement. Does it mean that they end up not doing so well in terms of academics? And the answer is no. There are many, many studies out there that have shown that there's no difference. If you make it to school, your results tend to be similar to the kids who are not exposed to anesthesia. And recently, there's been 2 prospective studies, the GAS study and the PANDA study, which are kind of reassuring and have shown that no association between a single brief GA exposure for surgery below the age of 3 and poorer neurodevelopmental score. So that's kind of reassuring. But I think there's enough evidence there to cause some worry and concern. But you say that's anesthesia, right? Our exposure is somewhat shorter, and our patients tend to be a little bit more well compared to kids in critical care. Well, given that you actually use sedatives for a lot longer than we do in anesthesia, there's surprisingly few studies on the impact of sedatives and analgesics in critical care. And because of the complex critical care environment, it's difficult to distinguish cause and effect. So sicker kids will tend to have more procedures done on them and probably will need more sedatives and analgesics. So we can't really distinguish the cause and effect. So far, there's no conclusive evidence, but again, sufficient to cause concern, and I'll show you a couple of these studies. So a lot of the studies are done in for what studies are done in neonates. The NeoPain trial is one of the largest ones. It's a randomized controlled trial of 900 neonates, preterm neonates who are ventilated in the NICU. They looked at a group with continuous morphine infusion compared to a placebo group with no morphine exposure. They find that continuous morphine infusion is associated with a longer duration on the mechanical ventilator and a longer time to full enteral feeding, which is not surprising. There's no difference in neonatal death and serious neurological complications between the groups. However, at follow-up at 5 to 7 years, the group reported lower body weight and head circumference in the morphine group, likewise poorer executive function and increased social problems, such as difficulty making and maintaining friendships in the morphine-related group. The EPIPAGE cohort is another study which looked at sedation and analgesia in very preterm infants on the mechanical ventilator. They had about 1,500 premature neonates on the mechanical ventilator. 115 of them were exposed to prolonged sedation, as they defined it as having sedation or analgesia for more than 7 days. They found that this group was more likely to have moderate or severe disability at 5 years, but at the same time, this group was also younger and sicker, and therefore they were at higher risk of developing disability anyway. So after adjusting for propensity score, they found that prolonged sedation, analgesia itself, is not associated with increased risk of disability at 5 years. So somewhat more reassuring. So Durden's group actually looked at neonates in the NICU as well. They looked at 138 preterm neonates, and they looked at their brains. Okay, so they did measure the hippocampal volume using MRI and diffusion tensor imaging at 32 weeks and at term. And they also did cognitive scores at 18 months using the Bayley scales of infant intelligence. So they found that if neonates were exposed to midazolam, the total midazolam dose correlated with lower hippocampal volumes and also lower cognitive scores. Okay, so that's a bit worrying. Whereas invasive procedures on their own did not seem to have this relation. They also found that surgery was highly associated with lower cognitive scores as well. So it may be the fact that they needed surgery. However, the group cautioned against the use of midazolam in preterm infants, neonates, particularly for those who are not undergoing surgery. So that's neonates. What about older children? Van Zillen looked at 77 meningococcal septic shock survivors with a median age of about 2 years. They found that out of these survivors, while they were in the ICU, about 60% of them received at least one sedative or analgesic drugs. If they were going to get one, benzodiazepine, half of them got benzodiazepines, and a third of them got opioids. And they did neurodevelopmental tests done at least 4 years after admission. And this group found that the use and the dose of opioids was associated with poor outcome independently, and outcomes in terms of lower verbal IQ, visual attention, and executive functioning. And this is independent of illness and severity scores. So I think you would agree with me just for hearing these 4 studies that could be potential concern here. So where do we go from here? Does it mean that we just stop using sedatives and analgesics in the ICU? Well, I think the answer is no, because we know that pain is bad too, right? So I think the key is to have a balanced approach. We want to balance the risk of untreated pain and distress versus the risk of exposure to sedatives and analgesics. In order to minimize the risk of untreated pain and distress, we would ideally decrease the frequency of painful procedures and also minimize environmental stresses such as noise, lighting, and so on, or do what we can. To minimize the risk of exposure to sedatives and analgesics, we really want to determine what is the optimal technique for relieving pain and stress in a particular patient. It could be a non-pharmacological technique, it could be regional, local anesthesia. And if we would really use sedatives and analgesics, we should use a titrated approach and with frequent assessment and adjustment to determine the optimal dosage. And it's also probably time for us to consider some what we call safer alternatives. Remember, I said vast majority of the anesthetic drugs that we use are associated with neurotoxicity, but there's a couple, for example, xenon, if you can use, or more practically, dexmedetomidine, which is alpha-2 agonist. It works, it's not an NMDA antagonist or GABA. Alpha-2 agonist, and in preclinical studies is very, very promising. Even at 10 times the dosage, it doesn't cause apoptosis. So it's something to think about. So in summary, we know that pain and stress is associated with negative physiological and psychological consequences, and it's to be avoided. Sedatives and analgesics also have adverse effects, including long-term effects on neurodevelopment. So we need a careful risk-benefit analysis, frequent reassessment, and titration in order to strike a fine balance between achieving effective sedation and analgesia while minimizing the adverse effects. Okay? With that, I thank you.